You had a peripheral nerve injury, lost strength in your foot, lost strength in your hand, and your doctor talked about doing a tendon transfer and you're confused? This video is for you. We will explain what a tendon is, who is a candidate for tendon transfer surgery, and when this surgery may or may not work. I'm here with Deborah, who is an occupational therapist, a specialist in hand treatment, and today we're going to talk a little with you who are going through this. Deborah, tell me something. Patients sometimes come to the office and say, "Doctor, I see this nerve jump when I move," and then we immediately understand that they are talking about a tendon. How do you explain to them what a tendon is?
I explain to them that the tendon is the final part of the muscle, that the muscle has a tendon part on one of its bones, then there's the muscle, and it ends with the tendon. That the nerve is something else, that the tendon is responsible for movement, and that the nerve needs to be there in the tendon, in the muscle, for it to have movement. So, I kind of differentiate it that way.
It's like the tendon is the rope, and the nerve is the power line, right? Right. And tell me something, tendon transfer is when you take a tendon and place it somewhere else. Do you prefer the patient to have a nerve transfer or a tendon transfer? Which do you see more results with? Or does it depend on each case?
I think it depends on each case. I think both give good results, and I just think that tendon transfer in some parts of the body is quicker and easier for the patient to understand. I think the corticalization is easier for the patient to learn than us working with this change of movement in the brain regarding the nerve.
Folks, tendon transfer or nerve transfer is when you lose a movement, for example, the movement of extending the wrist and fingers, meaning a patient who has a radial nerve injury and ends up with a dropped hand. We use the tendons that close the wrist and fingers to create a new function. It is difficult for a person to separate the area of the brain that performed the function of closing and then opening it. Dissociate the area that closes from the area that opens, because you always close everything together. How are you going to take half of these muscles that close and extend? So it's Deborah's job to do the rehabilitation and make the patient learn, right? Deborah, if you take a child, or a young adult or an elderly person, do you think you rehabilitate them in the same way to train this movement? Or do you think it's easier or harder in one of the cases?
It's not the same way with children. It's quite difficult, so much so that there are very few cases where transfers are done in children because they really can't achieve this dissociation, this corticalization. For the elderly, sometimes it's also quite difficult because they can no longer do this corticalization training. So, with young adults, it's always easier.
Why is it easier? Look, I see that you perform the same surgery on a person who really wants to improve and on someone who just does the exercise anyway or doesn't care much, and you see that the person who wants to improve and is dedicated improves a lot, right? I see that understanding the exercise and wanting to understand the exercise makes a big difference, especially in cases where I perform surgery for foot drop, because sometimes the person just takes a step the same way they did before. And then there's another person to whom I transfer the tendon that moves the foot inward, and they manage to use that tendon to lift the foot. And from the moment they manage to use it once, they start using it all the time, training and strengthening. What do you do to help this person understand this new movement, or a way for them to effectively use the tendon and understand that it performs a new movement? What do you usually do or advise?
So, we work a lot with imagery, again, both with mirrors, and by trying to perform the movement on the contralateral arm or leg until they can really grasp the movement, and then start doing it on the leg or arm where they had the transfer.
An advantage of tendon transfer compared to nerve transfer is the following. The patient undergoes surgery, we tie one tendon to another, and then from the moment they remove the cast, they can already use that tendon so they can effectively perform the movement and see the movement. The nerve patient, on the other hand, cannot see that movement. They spend many months imagining something that might eventually appear. So imagery in this case is much more difficult because an image is an image. If you can see it, it becomes much easier. Do you think that being able to see the movement after a tendon transfer leads to better results than a nerve transfer?
Certainly. So much so that we always start without gravity, because then the patient can really see the movement, and then they do it with the repetition of the visual, the movement, along with brain activation, they will achieve a good result.
And tell me something, if you had a radial nerve injury, leaving your hand drooping, and you could choose only one surgery to perform, and it would be the only one to give you a result, would you do a nerve transfer or a tendon transfer?
I would do a tendon transfer.
Yeah, I would also do a tendon transfer. Why would you choose a tendon transfer in this case?
Because the result is much faster if the person has a good surgery and starts treatment very early, which begins around 4 to 6 weeks. Post-operation, in 3 months, they are already able to use their hand well.
That's right, folks. So we take a strong tendon that works and attach it to another tendon that has no strength. You are looking at the tendon, you attach it, and you know that the strength it has here, it will exert there. The person just needs to learn and be able to use this tendon, so it is a surgery with a high success rate. So it's a surgery that, for me, is very worthwhile. You agree with that too, right?
I agree. I think it makes the person very functional in a very short period of time.
And do you think tendon surgery improves muscle strength or the amount of muscle a person has? That's a pretty common question, right?
I don't think so. The donor, both the donor and the recipient, won't have the same strength as before because both were sacrificed, so to speak. But they will have good strength power. Though it won't be the same as before because even if we do, let's say, hypertrophy work and such, it will always be a weaker muscle.
So we take the muscle that was tied here, untie it, and tie it here. The amount of muscle will be the same, right? And tell me something, what is the biggest challenge for patients who have just undergone a tendon transfer? What is the biggest difficulty they face in achieving the movement gains they want?
Understanding the transfer. Because often the patient arrives and they think it's something magical that they'll remove the splint and start moving right away. And it's not like that. There's a path we need to follow. So, the most complicated part is, it seems like they get somewhat frustrated, even though we explain, look, it's not like that. It doesn't happen automatically. But I think dealing with this kind of frustration is the most complicated part.
Tell me something, is there anything we can do before the surgery to prepare the patient so they can have the best outcome?
Yes, there is, Thomas. Ideally, we should strengthen the donor muscles before performing the surgery because the chance of a better outcome is higher since the tendon or muscle will be stronger than if we consider a person who has other injuries, not just the radial nerve injury, or sometimes depending on how long they've been inactive. That muscle has also suffered atrophy, so to speak, or lost mass, so we need to prepare this donor muscle to effectively perform where it will be donated.
Guys, look how interesting this is. So, we're going to take a muscle to perform a new function. At first, you can't make the movement with this muscle. The stronger it is, the stronger it will be in the place where it was transferred. So, what do I want to do? Lift my foot because I had a dropped foot. If I'm going to transfer the muscle that moves the foot inward, what can I do before the surgery? I can take an elastic band, hold the foot, and have the patient exert force to move the foot inward, so that muscle becomes much stronger. When we cut it and transfer it to another place, it usually loses a little strength. But if the patient has prepared for this, they will have a stronger muscle. They will notice the strength sooner, they will see the movement sooner, and this will even help them to have a neuroplasticity response sooner, right? So, strengthening is extremely important. And Deborah, tell me something. Have you ever seen a case where the patient loses the transfer? They exert too much force or stretch, and then the tendon that was tied comes loose?
I've seen it in some cases, but not losing the entire surgery, right? Sometimes just one or another muscle.
And what advice do you give to this patient so they don't lose the quality of the surgery? For example, I tell the patient that when I transfer the tendon for a dropped foot, especially women, not to wear high heels. Because high heels act as an orthosis to stretch the tendon I transferred, and the surgery is lost. For hand surgery, do you give any tips to the patient so they don't experience a loss in the quality of the surgery over time?
So, my guidance is, usually they remove the splint after 6 weeks. So, if they are still unsure, they can use the splint for 1 more week, because sometimes their hand becomes very stiff after being in the splint for 6 weeks. In a little while, when we see they are exerting force, a strong stretch to flex the wrist, they will stretch. If it doesn't tear, it might create a gap in the suture. So, until the 8th or 10th week, let the movement be natural. So, perform a wrist flexion. That they can do without stretching. Because we have patients who get desperate with their arm there, and then they end up stretching the tendon. So, that's the main guidance.
Folks, when we talk about tendon transfer, here's a tip. It's much easier to lose elasticity, meaning your hand is very extended after the transfer. You end up losing it over time rather than stretching, and then trying to gain it back, which you can't. So, don't stretch the tendon because you're in a hurry to release it quickly. Take it easy, lose it gradually, because later you'll have the range of motion to stretch. If you finish and remove the splint, and your hand is like this, if you stretch it downward, you'll manage to get it down, but then you won't be able to lift it anymore. That tendon that was tied, you stretched it too much and can't regain it. I often see this with tendon transfer surgery for a smile, because we leave the mouth more corrected, it's quite pulled, and sometimes the person spends 2 months with that very tight smile. They wear a mask and so on, and I say, don't rush to release the smile, because later it becomes difficult to pull when you want to smile. So, it's really quite interesting. And what about patients who, after a long time post-surgery, want to do weight training? Are you afraid of the tendon coming loose while doing weight training?
No, because after 3 or 4 months, everything is very well secured and healed. I'm not afraid.
I'm really scared, okay? Because otherwise, they'll say the surgery didn't work. Do you know why? Have you ever seen those videos of someone exercising at the gym and suddenly, their bicep bursts? There are patients who sometimes try to lift a very heavy weight, and there's a weakness there. Yes, I'm afraid of that.
But I think it depends on the load they lift.
Exactly.
So we have to guide them, and they need to take responsibility for it.
Exactly. Risk versus benefit. I say, do you want to do it? You can. But there's a risk of it coming loose, because there's a weakness there. It's not a tendon that was born that way.
But then they either have to exercise differently or lift less weight.
And remember this, the first surgery has a good outcome. The second surgery has a so-so outcome. Exactly. And the third one has a poor outcome. Yes. So if you tear a tendon that has already been repaired, to take that tendon and reattach it, the outcome might not be as good. So, take care of your tendon because it might be the only one that lifts your hand or your foot. So it's a very precious tendon for you for the rest of your life. You might miss it a lot when you're 80 years old, right? To help you walk. So, I would take good care of it. I always tell this to the patient because I'm afraid they might lose it. So, great. I think that's what we had to say about tendon transfers. If you really like this video, follow our channel, give it a like, because more information about nerve injuries and tendon injuries is coming soon.